നമസ്കാരം. എല്ലാവർക്കും വിനീതമായ നമസ്കാരം. A very good evening to one and all. ലോക സനാർബുദ മാസമായ പിങ്ക് ഒക്ടോബർ മാസത്തിനോടനുബന്ധിച്ച് ഇന്ത്യൻ റേഡിയോളജിക്കൽ ഇമേജിംഗ് അസോസിയേഷൻ IRIA, അസോസിയേഷൻ ഓഫ് മലയാളം മൂവി ആർട്ടിസ്റ്റ്, AMMA, സ്വസ്തി ഫൗണ്ടേഷൻ എന്നീ സംഘടനകൾ സംയുക്തമായി ഒക്ടോബർ 1 മുതൽ 30 വരെ സംഘടിപ്പിക്കുന്ന വെബിനാർ സീരീസ് ആണ് തിങ്ക് പിങ്ക് തിങ്ക് പ്രിവെന്റീവ് എന്ന വെബിനാർ സീരീസ്. ഈ വെബിനാർ സീരീസിന്റെ 9ാമത്തെ വെബിനാറിലേക്ക് ഇവരെയും ഹാർദമായി സ്വാഗതം ചെയ്യുന്നു. ഈ വെബിനാർ സീരീസ് ഉദ്ഘാടനം ചെയ്ത് പ്രശസ്ത സിനിമാ താരമായിട്ടുള്ള ശ്രീമതി മഞ്ജു വാര്യരാണ്. I would now like to warmly welcome each and every one of you to the 9th day of the webinar series, Think Pink, Think Preventive, jointly organized by IRIA, AMMA, and Swasthi Foundation as part of the World Breast Cancer Awareness Month. This webinar series has been organized as a curtain raiser event for the Global Preventive Onco Summit, which is going to happen between January 16th and 18th, 2026 at Trivandrum, which will be organized by Swasthi Foundation. നമുക്ക് ഇനി വെബിനാറിലേക്ക് കടക്കാം. ഇന്നത്തെ ഈ വെബിനാറിന്റെ അധ്യക്ഷ പദവി അലങ്കരിക്കുന്നത് ബഹുമാനപ്പെട്ട തിരുവനന്തപുരം ജില്ലാ കളക്ടർ ശ്രീമതി Anukumari IAS ആണ്. We are very honored to have with us District Collector of Trivandrum, ശ്രീമതി Anukumari IAS. Very shortly, I will just say a few words about Anu ma'am. Anu ma'am is an Indian Administrative Service Officer who secured All India second rank in 2017 Civil Service Examination on her second attempt. And after serving in the corporate sector for 9 years, she chose to dedicate herself to public service. And in the context of this webinar, let me add that she is an ambassador of good health and well-being because she recently successfully completed half marathon, that is 21.1 kilometer running non-stop. And therefore she is truly a very shining role model for preventive healthcare. And she is very passionate about many healthcare campaigns like organ donation, awareness, and registration. So we're very delighted to have you, ma'am, with us today. Let me now invite you for the presidential address for this webinar. Over to you, Anu ma'am.
Thank you, Dr. Devi. Thank you for the kind words spoken. Very happy to be here because honestly, I feel that this breast awareness month celebration, this is something which we genuinely need, and it is addressing a felt need in the society. So I'll just share one anecdote. When we were preparing for UPSC, so at that time, to most of the questions which used to come in the mains exam, we used to write answers. The last point almost often used to be awareness campaign should be done, and we will take care of ABC issue through IEC, information and educational campaigns. At that time, honestly, we used to write it without really thinking about it, just because we had read everywhere that awareness is the solution. But after coming into the services and after having started working on the field, I genuinely and truly feel to most of the problems, honestly, awareness is the solution. In that light, this campaign, what we are holding today, is highly needed, and the right kind of awareness among our women, among our daughters, our girls is very, very essential. So we always say that prevention is better than cure. This is almost like that only, that if unfortunately, if anybody gets inflicted with breast cancer, or for that matter, even other forms of cancer or disease, if we get to know about it in the initial stages, then definitely the chances of recovery, the chances of treating that disease are much more. But quite often, without knowing, we probably might not be doing simple self checks, or not even going for say medical examinations, which people say or doctors recommend that after a certain age we should be actually doing that every year. So that kind of awareness generation is highly required in the society, and in that light, the kind of webinar series that we are having, whether it is physical programs, online events, whatever be the mode, but while it is generating the right kind of knowledge in the society, so to that effect, it is very important. I myself, last year, what had happened was, last year, in fact, I had started feeling a stringing kind of pain in my chest area, and I had got very scared. Oh God, could it be breast cancer? So then I consulted the doctor, and the doctor assisted properly, told me, okay, nothing to worry about. And she also told me how to check it yourself. So that was the beginning for me. And with that kind of thing, I also understood that this self check and being aware about bodily changes and being conscious about that is a very important first step. So with that, I come to the end of my presidential address. I want to thank all the doctors, and I think AMMA representatives are also here, Malayali Actors Association, and all the people who have joined this webinar today. Those of you who already have the knowledge, please use that to spread more awareness in the society, all our doctors and experts. And those of you who are laymen like me, please use such opportunities to get yourself more aware about these things and then spread the message. So thanks to all the people involved in this, നമ്മുടെ എല്ലാ ഡോക്ടർമാർ and ബാക്കി എല്ലാ ആൾക്കാർ, thanks for inviting me. I formally invite this webinar series today. Thank you.
Thank you, ma'am. Thank you, ma'am, for joining us despite your very, very hectic schedule. And thank you for your inspiring words and inspiring presence. And we really hope that we can associate with District Collectorate of Trivandrum for many health-related campaigns, especially in the area of cancer detection, awareness, and prevention. ഇനി നമ്മുടെ ഈ webinar.
Dr. So,
Yeah,
for that, I actually would want, and Shankari is already in touch. So we would love to have you people in our civil station premises and have a campaign there also.
Sure, ma'am. Definitely we'll plan it out. Thank you, ma'am. Thank you, ma'am, for joining today. Thank you. ഇനി നമ്മുടെ ഈ വെബിനാറിന്റെ ഇനോഗ്രേഷൻ ആണ്. ഇന്നത്തെ ഈ വെബിനാറിന്റെ ഇനോഗ്രേഷൻ നിർവഹിക്കുന്നത് സിനിമാ രംഗത്തുള്ള ഒരു വിശിഷ്ട അതിഥിയാണ്. നമുക്ക് ഏവർക്കും സുപരിചിതനായിട്ടുള്ള GP എന്ന് വളരെ പോപ്പുലർ ആയിട്ട് അറിയപ്പെടുന്ന ശ്രീ ഗോവിന്ദ് പത്മസൂര്യയാണ്. കേരള സംസ്ഥാന അവാർഡ് നേടിയ അടയാളങ്ങൾ ദി ഇംപ്രിൻസ് എന്ന ഫീച്ചർ ഫിലിമിലൂടെ നായകനായി അരങ്ങേറ്റം കുറിച്ച് പ്രമുഖ നടനാണ് GP. ശ്രീ ഗോവിന്ദ് പത്മസൂര്യ is a very popular actor, producer and state award winning television host, and who has actually presented a lot of super hit reality shows on leading channels. So let me now invite Sri Govind Padmasoorya to formally inaugurate this webinar.
Thank you so much for that warm welcome. എൻ്റെ അടുത്ത് ഈ ഒരു വെബിനാറിനെ കുറിച്ച് പറഞ്ഞ സമയത്ത് ഞാൻ ആദ്യം വെബിനാർ എന്താണെന്ന് പറയുന്നതിന് മുമ്പ് തന്നെ ഞാൻ പറഞ്ഞത് 8th and 9th ഏതെങ്കിലും ഒരു ദിവസം ഇതിന്റെ ഭാഗമാവാൻ പറ്റുമോ എന്ന് ചോദിച്ചപ്പോൾ ഞാൻ പറഞ്ഞു അന്ന് വർക്ക് റിലേറ്റഡ് ആയിട്ടുള്ള ഒരു ട്രാവൽ ആയതും ഈ 7 o'clock ഞാൻ ആ സമയത്ത് ഫ്രീ ആയിരിക്കുമെന്ന് അറിയില്ല എന്ന് പറഞ്ഞിരുന്നു. ഇപ്പൊ ഇതിന്റെ തുടക്കത്തിൽ നിങ്ങൾ കാണുമ്പോൾ ഞാൻ നേരത്തെ വണ്ടിയിലായിരുന്നു, ഇപ്പൊ വേറൊരു സ്ഥലത്താണ്. പക്ഷെ വെബിനാർ എന്തിനെ കുറിച്ചാണ് എന്ന് പറഞ്ഞു കഴിഞ്ഞപ്പോ ഞാൻ ആദ്യം തന്നെ പറഞ്ഞത് നോക്കണ്ട, ഞാൻ അവൈലബിൾ ആയിരിക്കും ആ സമയത്ത് എവിടെയാണെങ്കിലും. ചിലപ്പോ ഒരു പക്ഷേ ഞാൻ വണ്ടിയിൽ ഇരുന്നിട്ടായിരിക്കും ഇത് അറ്റൻഡ് ചെയ്യുക, പക്ഷെ എനിക്ക് ഇതിന്റെ ഭാഗമാവണം എന്ന് ഞാൻ അങ്ങോട്ട് റിക്വസ്റ്റ് ചെയ്യുകയാണ് ചെയ്തത്. കാരണം ഐ ഫൗണ്ട് ഇറ്റ് വെരി റെലവെന്റ് ഓൾസോ. കാരണം അപ്പോൾ ഫസ്റ്റ് ഓഫ് ഓൾ ബിഗ് താങ്ക് യു ടു ഓൾ ദ അസോസിയേഷൻസ് ബിഹൈൻഡ് ദിസ്. ഇപ്പോൾ IRIA ആണെങ്കിലും സ്വസ്തി ആണെങ്കിലും ഞങ്ങളുടെ സ്വന്തം അമ്മയാണെങ്കിലും ദിസ് ഈസ് എ വെരി റെലവെന്റ് ആയിട്ടുള്ളൊരു ഒരു ഇനീഷ്യേറ്റീവ് ആണ്. ഇപ്പൊ ഇതിനകത്ത് നമ്മൾ പറയുന്ന ബ്രസ്റ്റ് ക്യാൻസർ അവയർനെസ് മന്തും അതുപോലെ തന്നെ ഗ്ലോബൽ പ്രിവെന്റീവ് ഓൺകോ സബ്മിറ്റിന്റെ കർട്ടൻ റേസറും, ഇത് രണ്ടും പറയുമ്പോൾ ഇതിനകത്ത് ഇൻട്രസ്റ്റിംഗ് ആയിട്ടുള്ള 2 ടാഗ് വേർഡ്സ് ആയിട്ട് എനിക്ക് തോന്നിയത് ഒന്ന് അവയർനെസ്, ഒന്ന് പ്രിവെന്റീവ്. ആൻഡ് ദാറ്റ് ഈസ് വാട്ട് ഇറ്റ് ഈസ് ഓൾ അബൌട്ട് എന്ന് എനിക്ക് തോന്നുന്നു. എസ്പെഷ്യലി സ്ത്രീകളുടെ കാര്യത്തിൽ എനിക്ക് എപ്പോഴും തോന്നിയിട്ടുള്ളത് എന്താന്ന് വെച്ച് കഴിഞ്ഞാൽ ദേ ആർ വെരി സെൽഫ്ലെസ്. ഈ കെയറിങ് എന്ന് പറയുന്നത് അവരുടെ ഒരു ആട്രിബ്യൂട്ട് ആണ്. അതുകൊണ്ട് തന്നെ ഈ കെയറിങ്ങിനോടൊപ്പം തന്നെ സെൽഫ്ലെസ്നെസ്സും ഇത്രയധികം വരുമ്പോൾ സ്വന്തം കാര്യം നോക്കൽ വളരെ കുറവാണ്. എപ്പോഴും ആളുകളെ കെയർ ചെയ്യുക എന്ന് പറയുന്നത് ഒരു ഫെമിനിൻ നേച്ചർ അത്രയും പ്രോമിനന്റ് ആവുമ്പോൾ സംടൈംസ് ദേ ഗോ ടു ദാറ്റ് എക്സ്റ്റെന്റ് വേർ സ്വന്തം കാര്യം നോക്കൽ എന്ന് പറയുന്നത് ഏറ്റവും ലാസ്റ്റ് കാര്യമായിട്ട് വരുന്ന ഒരു അവസ്ഥയിലേക്ക് അവരെത്തുന്നു. അങ്ങനത്തെ സമയത്ത് ഇതുപോലെയുള്ള ഇനീഷ്യേറ്റീവ് വളരെ ഇമ്പോർട്ടന്റ് ആണ്. ഇപ്പൊ ചെറിയൊരു കാര്യം പറഞ്ഞില്ല, നമ്മൾ ക്യാൻസർ വരെ ഒന്നും എത്തണ്ട. എനിക്ക് തോന്നിയിട്ടുള്ള ഒരു കാര്യം, ഇപ്പൊ ബ്ലഡ് ടെസ്റ്റ് ചെയ്യുക എന്ന് പറയുന്ന ഒരു കാര്യം വരുമ്പോ പലപ്പോഴും ഞാനടക്കമുള്ള ആളുകൾ ചോദിക്കാറുണ്ട്, എന്തിനാണ് ഒരു ബ്ലഡ് ടെസ്റ്റ് ചെയ്യുന്നത്, അതിനിപ്പോ നമുക്ക് ഒന്നും അതിന്റെ ആവശ്യമുണ്ടോന്ന്. പക്ഷെ പലപ്പോഴും ബ്ലഡ് ടെസ്റ്റ് ചെയ്ത് നോക്കുമ്പോഴാണ് ഒരു പക്ഷെ പ്രീ ഡയബറ്റിക് സ്റ്റേജിലാണ്, അല്ലെങ്കിൽ കൊളസ്ട്രോളിന്റെ ഇത് ഹൈ ആണ്, അല്ലെങ്കിൽ ഈ സമയത്ത് വിറ്റാമിൻ ഡി എന്ന് പറയുന്നത് എക്സ്ട്രീംലി ലോ ആണ്, അതുകൊണ്ടാണ് നിങ്ങൾക്ക് ഇത്രയും ക്ഷീണം എന്ന് പറയുന്ന സാധനങ്ങളൊക്കെ ചില സമയത്ത് എനിക്ക് വരികയും ജസ്റ്റ് ചെറിയ ഫുഡ് കൺട്രോൾ അല്ലെങ്കിൽ ചെറിയ രീതിയിൽ ആ സമയത്ത് പ്രിവെന്റീവ് മെഷേഴ്സ് എടുത്തത് കൊണ്ട് അതെല്ലാം നോർമൽ ആവുകയും ചെയ്യുന്ന അവസ്ഥ വരുമ്പോൾ ദെൻ ആഫ്റ്റർ എവറി 6 months ഇത് ചെയ്യാൻ ഒരു മടിയും തോന്നില്ല. കാരണം എന്താന്ന് വെച്ച് കഴിഞ്ഞാൽ സ്റ്റിച്ച് ഇൻ ടൈം സേവ്സ് 9 എന്ന് പറയുന്ന പോലെ ചെറിയ കുറച്ച് മരുന്നുകൾ പോലും ഇല്ലാതെ ഡയറ്റിൽ ചെറിയ വ്യത്യാസം വരുത്തിയപ്പോൾ ഓൾ ദ അതർ തിങ്സ് കൺട്രോളിലായി അല്ലെങ്കിൽ എന്നുള്ള അവയർനെസ് നമുക്ക് ഉണ്ടാവുമ്പോൾ പിന്നെ നമ്മൾ അതൊരു ഹാബിറ്റ് ആക്കി മാറ്റും. എവറി 6 months നമുക്ക് വെറുതെ ഒന്ന് ഇത് ചെക്ക് ചെയ്ത് നോക്കാം. എനിക്ക് തോന്നുന്നു ഇന്നത്തെ വെബിനാറിന്റെ ടോപ്പിക്കിൽ ഒരു കാര്യം സിംറ്റംസ് ഉണ്ടെങ്കിൽ അല്ലെങ്കിൽ സിംറ്റംസ് ഇല്ലെങ്കിൽ ചെക്ക് ചെയ്യണോ എന്നുള്ള ഒരു ടോപ്പിക്കാണ്. അതേപോലെ റെലവെന്റ് ആയിട്ട് തോന്നുന്ന എനിക്ക് വേറൊരു കാര്യം എന്താണെന്ന് അറിയോ, ഇപ്പൊ പലപ്പോഴും ബ്ലഡ് ചെക്ക് ചെയ്യാൻ പറയുമ്പോൾ അല്ലെങ്കിൽ ഇതുപോലെ ടെസ്റ്റ് ചെയ്യാൻ പറയുമ്പോൾ ആളുകൾ ചോദിക്കുന്നത് ഇപ്പൊ നമ്മൾ സമാധാനത്തോടെ ഇരിക്കുകയാണെങ്കിൽ ടെസ്റ്റ് ചെയ്ത് വല്ലതും ഉണ്ടെങ്കിലോ എന്നുള്ള പേടി കാരണവും ആളുകൾ ടെസ്റ്റ് ചെയ്യാതിരിക്കുന്ന അങ്ങനെ പല പല കാരണങ്ങളാണ് ഫോർ പീപ്പിൾ നോട്ട് ടു ഡു ദിസ് എന്ന് പറയുന്നത്. അപ്പൊ പലപ്പോഴും ആൻഡ് ഐ ഹാവ് റിയലൈസ്ഡ് ദാറ്റ് ഇപ്പൊ എനിക്ക് നമ്മുടെ ഡോക്ടർ സുഹൃത്തുക്കളുടെ അടുത്തുനിന്നും ഒക്കെ ഞാൻ മനസ്സിലാക്കിയ ഒരു കാര്യം അല്ലെങ്കിൽ പല അനക്ഡോട്ട്സും നമ്മൾ കേൾക്കുമ്പോൾ നമ്മൾ മനസ്സിലാക്കുന്നത് എന്താ വെച്ചാൽ ഈ ക്യാൻസർ പോലെയുള്ള അസുഖങ്ങൾക്ക് പ്രത്യേകം ചിലതിന് പ്രത്യേകിച്ച് സിംറ്റംസ് പോലും ഇല്ല, 4th സ്റ്റേജിലൊക്കെയാണ് അറിയുന്നത്, അപ്പോഴേക്കും ഇറ്റ്സ് ടു ലേറ്റ്. നേരത്തെ അറിഞ്ഞിരുന്നെങ്കിൽ എന്ന് പറയുന്ന വാട്ട് ഇഫ് യു ഹാഡ് ടെസ്റ്റഡ് ബിഫോർ എന്ന് പറയുന്ന സിറ്റുവേഷൻസ് കുറെ ഉണ്ടാവുന്നുണ്ട് എന്നൊക്കെ അറിയാനിടയായി. അപ്പൊ അങ്ങനത്തെ ഒരു അവസ്ഥയിൽ തീർച്ചയായിട്ടും ദിസ് ഇസ് വെരി റെലവെന്റ്. സോ വൺസ് അഗെയിൻ ഒരു ബിഗ് റൗണ്ട് ഓഫ് അപ്ലോസ് ആൻഡ് അഭിനന്ദനങ്ങൾ ടു ദ ഹോൾ അസോസിയേഷൻ ഇങ്ങനെ ഈ ഒരു ഇനീഷ്യേറ്റീവ് എടുത്ത്. എനിക്ക് തോന്നുന്ന അമ്മ അസോസിയേഷനിൽ മെജോറിറ്റി എന്ന് പറയുന്നത് സ്ത്രീകളാണ്. മാത്രമല്ല ഇപ്പൊ ഞങ്ങളുടെ ഇലക്ഷൻ കഴിഞ്ഞപ്പോൾ അതിന്റെ ശക്തി കൂടി, അസോസിയേഷന്റെ വെൽ ബാലൻസ്ഡ് അല്ലെങ്കിൽ തലപ്പത്ത് ഇരിക്കുന്നതൊക്കെ സ്ത്രീകളാണ്. ആൻഡ് ഐ തിങ്ക് ദിസ് ഇസ് ദ ഫസ്റ്റ് മേജർ ഇനീഷ്യേറ്റീവ് ആഫ്റ്റർ ഇലക്ഷനൊക്കെ ശേഷമുള്ള ഒരു മേജർ ഇനീഷ്യേറ്റീവ് ആണ് ഫ്രം ദ കോർ ടീം. ആൻഡ് അതൊരു പ്രശംസനീയം തന്നെയാണ്. ആൻഡ് ഐ എം വെരി ഹാപ്പി നമ്മളെ പോലെയുള്ള ആളുകളെ ഓർത്ത് ഇതിന്റെ ഭാഗമാക്കുന്നതിലും. കാരണം ഐ തിങ്ക് ദാറ്റ് ഇറ്റ് ഇസ് സ്ത്രീകൾ മാത്രമല്ല പുരുഷന്മാരും ഇതിനെക്കുറിച്ച് അവെയർ ആവേണ്ടതാണ്. എവ്രി വൺ ഷുഡ് ബി അവെയർ ഓഫ് ഇറ്റ് സോ ദാറ്റ് അത് അതിന്റെ എഫക്റ്റീവ്നെസ്സിൽ നമുക്ക് മുന്നോട്ട് കൊണ്ടുപോകാൻ പറ്റും എന്നുള്ളത്. അപ്പോൾ ഇത് അറ്റൻഡ് ചെയ്യുന്നവരും എല്ലാവർക്കും ഇതൊരു ഓപ്പർച്യൂണിറ്റി ആണ്. 11 ജില്ലയിലോട്ടോ അതിന്റെ ടെസ്റ്റുകളും സ്കാനുകളും കാര്യങ്ങളൊക്കെ നടക്കുന്നുണ്ട്. സോ this is not a small thing. Let this be a beginning of a great association, great initiative. എല്ലാവർക്കും ഇത് ഗുണമാവട്ടെ. കാരണം നമ്മൾ പലപ്പോഴും യൂസ് ചെയ്യുന്ന ഒരു ടേമാണ് ലൈഫ് ചേഞ്ചിങ് എന്ന് പറയുന്ന കാര്യങ്ങൾ. അത് നമ്മൾ ഒരുപാട് ഉപയോഗിക്കുന്നതാണ്. പക്ഷെ എനിക്ക് തോന്നുന്നു ഇതുപോലത്തെ സാധനങ്ങളാണ് കൂടുതൽ അതിനെ അർത്ഥവത്താക്കുന്നത്. ഇത് ശരിക്കും ഒരു ലൈഫ് ചേഞ്ചിങ് ആയിട്ടുള്ള ഒരു ഇനീഷ്യേറ്റീവ് ആണ്. ആൻഡ് വൺസ് അഗൈൻ കൺഗ്രാറ്റുലേഷൻസ്. ആൻഡ് ഈ ഒരു ഇനീഷ്യേറ്റീവിന്റെ ഭാഗമായ IRIA, സ്വസ്തി, അമ്മ, നമുക്ക് ഒരുപാട് അഭിമാനമുണ്ട് നമ്മുടെ അസോസിയേഷൻ ഇങ്ങനത്തെ ഇനീഷ്യേറ്റീവ്സിന്റെ ഭാഗമാവുന്നു എന്നുള്ളതിൽ. സോ ഇത് കൂടുതൽ ഫ്രൂട്ട്ഫുൾ ആവട്ടെ. ഇന്നിപ്പോ വെബിനാറിന്റെ ഭാഗമായിട്ട് അതിന്റെ ടെക്നോളജിയെ കുറിച്ചും അതിന്റെ പുതിയ നൂതനമായ കാര്യങ്ങളെ കുറിച്ചും ഇൻഫാക്ട് AI വെച്ചിട്ടുള്ള ഫോർകാസ്റ്റിനെ കുറിച്ചൊക്കെ ഡോക്ടേഴ്സ് സംസാരിക്കുന്നു, പ്രതീക്ഷിക്കുന്നു. സോ താങ്ക് യു സോ മച്ച്. ഞങ്ങളെ കൊണ്ടാവുന്ന രീതിയിൽ സെലിബ്രിറ്റീസ് എങ്ങനെയാണ് ഇത് ആളുകളിലേക്ക് എത്തിക്കാൻ പറ്റുന്നത് ഞങ്ങൾ അത് ശ്രമിച്ചുകൊണ്ടേയിരിക്കാം. സോ ഒഫീഷ്യലി ഔപചാരികമായിട്ട് ഈ ഒരു വെബിനാർ ഞാൻ ഉദ്ഘാടനം ചെയ്യുന്നു. ഇത് എല്ലാവർക്കും ഗുണമാവട്ടെ.
Thank you, Sri Govind, for joining us and inaugurating this webinar. A lot of relevant and informative points from your side, and thanks for acknowledging the women power at AMMA and empathizing with the women community. And തിരക്കേറിയ സമയത്ത് ഞങ്ങളോടൊപ്പം ഈ വെബിനാറിൽ ജോയിൻ ചെയ്യുകയും ഇത് ഇനോഗ്രേറ്റ് ചെയ്യുകയും മാത്രമല്ല വളരെ വിലപ്പെട്ട അഭിപ്രായങ്ങൾ രേഖപ്പെടുത്തി ഈ ഒരു സംരംഭം വിജയിപ്പിക്കാൻ കാണിച്ച താങ്കളുടെ സന്മനസ്സിന് എല്ലാവിധ നന്ദിയും എല്ലാ അസോസിയേഷൻസിന്റെ പേരിലും പറയുകയാണ്. താങ്ക് യു വെരി മച്ച്.
താങ്ക് യു സോ മച്ച്.
അടുത്തതായിട്ട് നമ്മുടെ ടെക്നിക്കൽ സെഷൻസ് സ്റ്റാർട്ട് ചെയ്യാണ്. വി ആർ കമൻസിംഗ് വിത്ത് ദ ടെക്നിക്കൽ സെഷൻസ്. ഫോർ ചെയറിംഗ് ദിസ് ടെക്നിക്കൽ സെഷൻ, ലെറ്റ് മി ഫസ്റ്റ് ഇൻവൈറ്റ് ഡോക്ടർ റോയ്, Professor and Head of the Department Radio Diagnosis, Sri Gokulam Medical College. Over to Dr. Roy.
A very good evening to one and all. I hope I am audible.
Yes, sir.
Okay. അത് 1-2 വേർഡ്സ് ഇൻട്രഡക്ടറി മലയാളത്തിൽ പറഞ്ഞോട്ടെ. അമ്മ അസോസിയേഷനും IRIയും സ്വസ്തി ഫൗണ്ടേഷനും ചേർന്ന് നടത്തുന്ന ഈ ഒരു ബ്രസ്റ്റ് അവയർനെസ് ക്യാമ്പയിൻ എന്തുകൊണ്ടും അഭിനന്ദനം അർഹിക്കുന്നു. ഇതിൽ ഒറ്റ ഒരു മെസ്സേജാണ് നമുക്ക് നമ്മുടെ നാട്ടുകാരോടും പൊതുജനത്തിനോടും കൊടുക്കാനുള്ളത്. നിങ്ങൾ 40 വയസ്സ് കഴിഞ്ഞ ഒരു സ്ത്രീ ആണെങ്കിൽ നിങ്ങൾ ഒരു പ്രാവശ്യം ഒരു മാമോഗ്രാം ചെയ്തിരിക്കണം. നേരത്തെ നമ്മളത് 50 വയസ്സായിരുന്നു, പിന്നീട് അത് 40 വയസ്സായി കുറച്ചു. കാരണം 40നും 50നും വയസ്സിനിടയ്ക്ക് സ്റ്റേജ് 4 ക്യാൻസറിൽ പ്രസന്റ് ചെയ്യുന്ന സ്ത്രീകളുടെ എണ്ണം ഒരുപാടുണ്ടായിരുന്നു. അപ്പോൾ ഇതൊരു പ്രിവെന്റീവും കൂടെയാണ്. ഡിസീസ് വരാതിരിക്കാനല്ല, ഒരു സ്റ്റേജ് 4 ബ്രസ്റ്റ് ക്യാൻസർ പ്രിവെന്റ് ചെയ്യുന്നതിന് വേണ്ടിയിട്ടാണ് മാമോഗ്രാം ചെയ്യണം എന്ന് പറയുന്നത്. കാരണം സ്റ്റേജ് 4 വന്ന് ഒരു ഡെത്തിലോട്ട് പോകുന്ന അവസ്ഥയിൽ നിന്ന് രക്ഷിക്കുക എന്നുള്ളതാണ്. ഇന്നിപ്പോൾ കേരളത്തിലെ 1% ഈ പറഞ്ഞ 40 വയസ്സിനും 70 വയസ്സിനും ഇടയ്ക്കുള്ള സ്ത്രീകൾ 1% പേർ പോലും മാമോഗ്രാം ചെയ്യുന്നില്ല എന്നുള്ളതാണ് വസ്തുത. അപ്പോൾ ഈ 1% മാറി അത് 99%ത്തിലേക്ക് എത്തിക്കുക ഇൻ ദ കമ്മിങ് 5 years or so. അതാണ് നമ്മുടെ ലക്ഷ്യം. അപ്പോൾ വളരെ ദുർഘടം വരുന്ന ഒരു സ്റ്റേജ് 4നെ രക്ഷിക്കുക, പ്രിവെൻറ്റീവ് ആണ് ഇതിൻ്റെ മെസ്സേജ്. ഒറ്റ മെസ്സേജേ ഉള്ളൂ. അപ്പോൾ ഒരു സംശയം വരാം, മാമോഗ്രാം ചെയ്യുമ്പോൾ എക്സ്റേ അല്ലേ, അത് നമുക്ക് ശരീരത്തിന് ദോഷമല്ലേ എന്ന് ചിലർ ചോദിക്കുന്നുണ്ടാവാം. അതിനെനിക്ക് പറയാനുള്ളത്, കേരളത്തിൽ ജീവിക്കുന്ന എല്ലാവർക്കും ബാക്ക്ഗ്രൗണ്ട് റേഡിയേഷൻ ഒരു പരിധിവരെ കിട്ടുന്നുണ്ട്. ആ ബാക്ക്ഗ്രൗണ്ട് റേഡിയേഷൻ 1 വർഷം കിട്ടുന്നതിൻ്റെ പകുതി പോലും ഒരു മാമോഗ്രാം എടുക്കുമ്പോൾ നിങ്ങൾക്ക് ലഭിക്കുന്നില്ല. അതായത് നെഗ്ലിജിബിൾ റേഡിയേഷൻ ഡോസ് മാത്രമാണ് 40 വയസ്സ് കഴിഞ്ഞ സ്ത്രീ മാമോഗ്രാം എടുക്കുമ്പോൾ കിട്ടുന്നത്. അപ്പം അങ്ങനെ ഒരു പേടിയും വേണ്ട. അപ്പം അതുകൊണ്ട് ഇതൊരു ശീലമാക്കുക, ഇതൊരു സംസാര വിഷയമാക്കുക, ഇത് മുന്നോട്ട് കൊണ്ടുപോകുക. Now coming to the topics, today we have got two eminent doctors, Dr. Anusha Varghese speaking on artificial intelligence and Dr. Praveen Kesav speaking about advances in MR and other technologies for detecting breast cancer. They will be speaking in detail about this. Over to the anchor. Thank you so much.
Thank you, Dr. Roy, for sharing the session and sharing very valuable insights. So, നമ്മുടെ മാമോഗ്രാമിന്റെ ഒരു as a screening test reach 1% ആണ്. It should reach 95%. Maybe this webinar series will help in that endeavor. Now, let me now invite Dr. Praveen Keshava, Head of Interventional Radiology, GG Hospital and Sri Gokulam Medical College, for the first expert talk on the topic, newer advances in imaging, MRI, tomosynthesis, and AI-based screening. Over to Dr. Praveen Keshav.
Hi, good evening, everybody. Thank you, ma'am. Thank you for the warm welcome, and real thank you to AMMA Association, to Swasthi, and to Kerala IRIA for initiating this Preventive Radiology Summit. And this is something which is going to work in favor of people, and it is going to save a lot of life of women who may be our mothers, grandmothers, sisters, wife, or our daughters also, because it's going to make a big change, right? And I'm happy to be offered a chance to be part of this. And like our favorite celebrity GP sir told, our women are usually known for being very, very, very selfless. I think it's time they just start being slightly, at least a little bit selfish regarding their own health. So with that, let's see in what way we can help women imaging in breast cancer. So moving on to the topic per se. So I'll be talking about the fundamentals of breast imaging, the traditional modalities which have been available, and what has been the recent updates, and what we can do currently, and how are these helping people, and then how radiology is moving beyond imaging and helping in treatment protocols, and in what form can AI help us in getting the screening program even better. Right. So the fundamentals of breast cancer screening is that the global prevalence of cancer is definitely increasing, and breast cancer is one of the most common cancers in women. though there are genetic, environmental, and lifestyle factors involved, there are a lot of other factors also contribute to this cancer. And integration of all this into screening programs, we have realized that there is a lot of breast cancer which can be diagnosed probably in its very early stages before it starts causing any symptoms. And this is something called as latency period, right? So the image that you can see here, you can just have my pointer on. Yeah, so you can see that there's a normal cell here. Because of recurrent injury or genetic mutations and such things, it forms into a dysplasia where it's not a cancer yet. Then it becomes a cancer which is just starting to begin, and then it becomes a malignant conversion from there where it can start spreading to other locations. So this gap, this latency between when a dysplasia happens and this point where it becomes a malignant conversion, where it starts showing symptoms for the patient, the imaging or the tests that we do in this period where before the patient becomes symptomatic, where we can pick up the cancer in a very early stage and completely cure a patient from the cancer, is what is called as a screening modality, which could be blood investigations and or imaging. Now, as far as breast cancer is concerned, it comes down to mammography, right? So and now we have to decide. Okay, so that's going to be a screening program. So what time do we screen and what modalities do we have in offer? So the timing, as sir told, Roy sir told just now, anybody above the age of 40 has to undergo a screening mammogram, and anybody who has a family history of breast cancer has to undergo a screening mammogram at least 5 years prior to the onset of cancer in the relative. We have had patients like who had friends who had got diagnosed with cancer, probably stage 4 or stage 3, and they just got scared and got examined. Probably they'll be around 30-35 years age, and they just got this done just to be sure that nothing is wrong. They have literally no symptoms, and on screening they pick up that they have a cancer which is not yet manifested. And that's where imaging saves lives. Okay, we can completely cure patients. We have cured patients like that, and they are just continuing to carry on with their own life beyond that. So optimizing screening protocols and considering all the risk factors, like how I said, we screen patients not just by age, but by including the other factors like genetics and other things, and get a preventive screening done according to their risk of cancer. Now, the traditional imaging modalities that have been available are mammography. So it's just a simple imaging tool. As you can see here, the breast tissue is compressed by this paddle. It's not a major compression, it's just a soft compression so that the
Dr.
breast
Praveen,
tissue.
the screen is not visible to me. I don't know what about others.
Is it?
It is
Doctor?
visible, sir. It is visible.
It's visible, sir.
Yeah, so the paddles just give a gentle compression so that the breast tissue is uniformly distributed, and then we pass X-rays, very low dose of X-ray radiation, and as sir told, it's even lower than the routine radiation exposure that you're getting from the environment. And this helps us in evaluating the breast tissue and picking up lesions even when they are very small. And it has definitely shown that this modality is one of the best things in reducing the mortality related to breast cancer, because we are obviously picking it up at an early stage. Now, the main limitation of this mammography is the tissue density. Let us say there is a lot more dense tissue, then to differentiate the cancer from the normal dense tissue is slightly difficult. We'll come to that point, and how we can circumvent that is at many times using ultrasound. So let's say we have a patient with a dense breast, or let us say the screening mammography has found out some abnormality, then we convert that screening mammography to a diagnostic mammography. That is, whenever there is a positive finding, or whenever there is a dense breast, or when the patient presents to you with complaints of some discomfort in the breast, could be lumpiness, could be pain, or could be just some vague symptoms. And at that point, you always go for a diagnostic mammography. So diagnostic mammography is when you combine the X-ray mammography with an ultrasound screening. right? On ultrasound, as you can see here, tiny lesions like the breast lesions can be more easily picked up. Now, the next question will be, if ultrasound can become a adjunct, why not make that as the primary modality, right? Because ultrasound has its own issues with operator variability and the technical factors associated with it, and not every breast will show positive findings, and there will be many findings picked up on ultrasound which may not be actually tumorous, right? So X-ray mammography is the baseline, and the X-ray findings that you find, you correlate with an ultrasound, and that gives us a even better evaluation of the patient. Now there are modalities like MRI, CT. As far as breast imaging is concerned, the imaging of breast, CT practically has not much of a role. So we move on to MRI, because MRI, the soft tissue resolution is breast. There is no bone involved. Whenever bone or tissues inside the body have to be evaluated, CT can be a good modality. But when it comes to soft tissue, MRI is far, far, far better. It has a very high sensitivity. It will pick up even tiny lesions which can be missed on X-ray. But that is also its negative aspect, that it can pick up very tiny things, but it will not give you a conclusive report in certain situations. So it can create unnecessary anxiety in patients, leading to, let us say, let's say we start doing MRI for all patients. Practically, it's not feasible because of the time and the cost factor. And if at all somebody wants to get an MR screening because they're scared about the unrealistic scare about radiation or ultrasound, they can get it done. But the thing is, the findings may not be always specific, especially tiny findings, and these tiny findings can lead to unnecessary anxiety. They may not be actually cancers. So MRI is a modality which we use for confirming cancers which are not yet confirmed on X-ray or ultrasound. And whenever the patient has a family history, and whenever there is multiple tumors, MRI is definitely the go-to modality to plan the treatment part. So MRI has a primary role in treatment, and the role in screening is very, very, very limited. Yeah. So the recent innovations in mammography has been the breast tomosynthesis. So in mammography, what we do is an X-ray is passed from above and below, and we just take an X-ray film. In tomosynthesis, what is done is serially multiple X-rays are taken from different angles. So this gives us a better interpretation of tissues, and even dense breasts, we can use mammography to gauge all the different slices, and this helps us in picking up lesions which may be missed in just a conventional mammography. So that's how tomosynthesis is better. And now recently we have contrast enhanced mammography, wherein we inject contrast and serial mammographies are done. And what will happen is, before giving contrast, we take an image, and after giving contrast, we will take serial images, and we will subtract the baseline images. So only things which are abnormally enhancing will be showed up. As you can see, this is the same breast being imaged. All the surrounding dense breast tissue which is not showing any significant enhancement gets suppressed in this contrast enhanced mammography. So even tiny lesions can be picked up, especially in patients who are having dense breast. This can be a very good modality, right? So the challenges and limitations in breast imaging, as I was telling, with the main problem with X-ray mammography is that with dense breast, it can lead to false negatives. That is, the dense breast is hiding the tumor within, right? I'll just show you an example of this. Just consider these star mark things as a breast lesion, and we have different types of breast density tissues. This is a low density tissue. This is a slightly higher density. This is a moderate density, and this is a very high density. You can see that the entire lesion is completely concealed by the dense breast tissue. So this is what we are talking about, missing lesions because of breast densities. This can be circumvented by using tomosynthesis, and also correlating an X-ray mammography with a corresponding ultrasound sonomammography. Now, MRI, the problem with MRI is using it for screening is the high false positive rates, as it can pick up even very tiny things which are not actually malignant, but can result in unnecessary anxiety for the patients. Right. And radiology is starting to move beyond imaging in breast cancer. And yeah, we are moving into preventive radiology. That is, we were doing screening, and we are moving into preventive radiology, where we want to prevent an incurable malignancy from developing. And we are moving in the other direction as well, that is in providing treatment options, right? So that's where comes our role in biopsies, fiducials, wire localizations, and ablations. Many times when these tumors are picked up, they are very tiny, hardly 3 mm, 5 mm, 1 centimeter, where it cannot be palpated. So what we do is, even otherwise what we do is, whenever a tumor is diagnosed, you have to get a biopsy. So this biopsy helps in treatment planning. We do a genetic analysis of the tumor cells by taking a biopsy. Biopsy is basically just a ultrasound guided sampling of the lesion, which cannot be felt by hand, but it can be seen on ultrasound. So we ultrasound guidance, we can take a sampling. So once the sampling is done, we get the diagnosis, we get the hormone receptor status or the genetic analysis, and based on that, the treatment protocol is very much fine-tuned according to the cancer, according to the patient and what they can tolerate. Now, let us say the patient requires a pre-procedure, the pre-operative chemotherapy. When you give chemotherapy, the entire lesion can disappear. So what we do is we just mark it with small radio-opaque particles called fiducials. Fiducial is basically a memory agent. So wherever the tumor was there, we will mark it with a fiducial. And once the chemo is given and the tumor is completely not visualized on ultrasound, we will mark these fiducials using wires. So we will mark wherever the fiducials are there, and then the corresponding area is taken out by the surgeon with a margin. So that is what is called as wire localization. And ablations are just coming up in patients who cannot be operated, or there is some contraindications. It's a very tiny tumors. Ablations, and also for benign breast lesions, ablations are coming up, wherein we can avoid surgeries, and using needles without any open surgeries, we can completely ablate. Ablation is basically you generate heat at the tip of the needle, and this heat destroys the tumor. That is what is called as the process of ablation. So without any surgeries, we can treat tumors, but that's limited for a very small spectrum of cancers at present. Now, moving on to artificial intelligence in breast cancer screening, things are just coming up. We have started with computer-aided detection and diagnosis. So a radiologist is going to see this mammography and is going to have his or her own interpretation of the mammogram. And then in addition, we will use computer-aided detection, wherein the computer will give us an idea that there are some areas which to me is probably looking like not the usual mammograms that I have seen. And the radiologist will be the one who will be looking at these areas in more depth, probably with a tomosynthesis or an ultrasound, or suggest an MRI, and then give a better report. So this is computer-aided diagnosis. Now, AI algorithms is basically the AI is going to analyze all these things, and then it has to it will analyze millions of images, correlate it with the corresponding other modalities with which we have used to finally diagnose what that particular area is. Let's say it could be a biopsy, it could be tomo or MRI, or just follow-up. And it will correlate all this and then come to a conclusion, right? So when we use AI to use an image and it comes out with a recommendation that no, this looks like an abnormality, that is what is AI integration. We are just reaching there. We are not yet into a stage where we can completely depend on AI, but we are definitely reaching there. We are getting there. And case studies in the current clinical use is basically limited to research modalities. And the main problem with AI anywhere is the black box enigma. Where you don't know what is happening inside the black box. That is a problem. So how far can you trust AI is going to be the issues. The credibility, transparency, and utility of AI is going to get questioned, and it will require detailed discussions regarding how we are going to proceed with AI and how much are we going to depend on it. And based on that, we will slowly integrate AI into the diagnostic tools, like how we have integrated CAD already. From there, we'll move on to AI and clinical data utilization. And this AI will not be limited to diagnosis, right? So whether it is abnormal or normal, it will be into whether it is cancer. What if we can, using texture analysis and stuff, and we can basically, predict even the hormone receptor or genetics, or which part of genetic has, genetic problem has caused this tumor development, can also be predicted probably with AI in future. That's where we are heading to. Now, the AI integrations, when we start doing what it will do is, the primary aim here is as was being discussed during the introductory part, is that the breast cancer screening is at 1%. Now we want that to become 95% or 99%. Now, when so many people are going to get screened, obviously the possibility of a cancer being detected is going to be between 1 to 5% in the general population. Now, just imagine a radiologist going through hundreds of scans and picking up this 1 to 5%. Right? So that is where I know that it's going to be an overwork. We may not have enough radiologists for such huge volumes. So at that point, to improve the sensitivity and specificity, AI definitely has a role. It will screen the MRA and give it to us. And this would increase the efficiency or workload reduce the unnecessary workload and improve the workflow efficiency of radiologists and help us in screening all the abnormal mammographies and then going ahead in detail and discuss and evaluate those ones and, pick up the, spend time in areas where it is actually required. So for mass screening, definitely AI integration would pave the way forward. And as I told, into personalized risk assessment, screening, and treatment protocol, AI is also going to help us in tailored screening protocols as per the patient's genetics, as per the patient's family history, integrating the family history of the patient into that, and then personalizing the scan, how frequently the scanning has to be done, etc. So to conclude, imaging is definitely moving forward rapidly, and with AI integration, we can definitely go into mass screening programs. And also, whenever we are going to pick up, we can integrate AI to provide us with personalized care, which will definitely impact the treatment outcomes.
Thank you, Dr. Praveen, for that explaining everything in detail, especially technically and in depth, and making this webinar very, very informative. So if anybody has any questions to ask Dr. Praveen, you can do so now or post your message in the chat box also. Meanwhile, Dr. ഒരു സംശയം ചോദിച്ചോട്ടെ, നമ്മൾ എപ്പോഴും ഒരു ഫ്രം ദ പബ്ലിക് സൈഡിൽ നിന്ന് കേൾക്കുന്ന ഒരു കാര്യമാണ്, നമ്മൾ എപ്പോഴും MRIയുടെ കാര്യം പറയുമ്പോൾ, the new MRI takes less time, less noise and compared to the traditional, what you call traditional ones?
Yes, ma'am. We are moving into the era of silent MRA. So yes, MRA, as you can hear in the background, I'm having some drilling noise going on in the background. So MRA is a troublesome one. Just imagine 10 times this noise, banging on your head while you're getting an MRA done. So that is definitely a problem that is getting sorted out. And we are definitely moving on to faster and faster MRAs. Even the 1.5 Tesla MRAs are getting faster. When we go for higher magnets, we can get faster images, better quality images as well. So yes, MRA is definitely getting faster and more silent.
Well, that is great news. And another point is that are these newer methods of imaging technology available in all regular hospitals, or is it's only available in like tertiary cancer care centers?
So the modalities like X-ray mammography along with a correlation ultrasound, which forms the core in screening program, is available in almost all the hospitals. And even many scan centers are having both the modalities. And as far as MRI is concerned, definitely we are getting there. It's not available freely in all the hospitals, but in most places it is available. But if you ask me whether it is required for screening purposes, probably not. So probably we need not worry about the MRA part. And tomosynthesis is one thing, again, it's a recent entity, so that is also coming forward. But to be fair enough, I think an X-ray mammogram with a correlation ultrasound is usually more than enough to do your screening, diagnose, and plan your treatment.
Thank you for that information. And one more last question, like you were talking about AI. So what happens if AI makes a mistake? So who is going to
Definitely. So
double check
that's the black box enigma. We don't know how it is working. So we cannot make it fail proof unless we understand how it is actually working. So that is going to be it's a tedious process where we sit in, we analyze whether the AI is functioning properly with proper feedback loop we have to generate, and there has to be a sample population of reports or X-ray mammograms which the AI is rejected as normal, get back them, take a small sample size and evaluate them, and find out whether the AI is doing mistakes. So it's going to be a long process. It's not going to be simple, but yeah, definitely we are getting there.
Okay, thank you so much, Dr. Praveen. Now we'll come to the next expert talk. Let me now invite Dr. Anusha Varghese. Head of the Department and Senior Consultant, Department of Radiology, Ludes Hospital, Kochi, for the expert talk on the topic. Myth screening is needed only when there are symptoms. Over to Dr. Anusha.
Good evening, everybody. Am I audible?
Yes, ma'am, you are audible.
Okay. Thanks for the introduction, Dr. Devi. Good evening, Dr. Roy, sir. Heard the wonderful introduction to today's evening by Govind, sign personality, and the expert talk by Dr. Praveen in great detail about the advances on breast imaging. My topic is more simple. Is my screen visible?
Yes.
Okay, today my topic is myths about breast screen. In a country such as India, which has so many religions, languages, cultures, and castes still playing an important part, there are so many myths and traditions which are difficult to erase from society. So we should reach to the grassroots level and work to help the public get freed from all these invisible tentacles and come to medical fraternity for help. Our aim, as Roy sir and Dr. Praveen had said, is to increase the approach of screening and make it reach the public. Remove or dispel the fears and increase the availability. So in Indian scenario, the Breast Imaging Society and in various other nations around the world, such as American Cancer Society, National Health Service Breast Screening Program in UK, and NCCN in other parts of the world are setting the guidelines. Breast awareness. Breast awareness. You have to get to know your breast, the normal look and the feel. That will help in a long way to detect any slight change in that.
Language to the next generation. Maharashtra houses 25% of India's libraries and over 200 Marathi festivals are held annually. A Marathi center with the Chhatrapati Shivaji Maharaj Memorial will be set up in Delhi.
Hello.
Chief Minister Devi inaugurated the cycle event. The campaign has
Hello, am I audible?
Shamini, can you just unmute? Mute, because we are having this, I think, yeah.
Thank you.
Now we can continue.
So breast awareness is the primary aim of the program, including today's, to increase the awareness
Anusha,
of
can
your
you
own.
make it into slideshow mode?
Yes.
The slides are visible actually.
1 second.
Okay, please.
Now? Now,
Yes, Kandika.
Now it is visible.
Thank you. So self-breast examination should be explained to the whole of the public, and they should be able to do it on a monthly basis. Subsequently, the individual women should be encouraged to approach a health professional, a doctor, usually the family physician or the gynecologist, with the change that they observe in their own breast, and subsequently be referred to radiology if any investigation is needed. Clinical breast examination is when the breast examination is done by a health professional. Now, what is self-breast examination? What is self-breast examination? As shown, any woman in the menstruating age group has to select a particular day after the menstruation cycle. So after the period is the time when the person is best suited for breast examination. When in the postmenopausal group or the post-hysterectomy group, then they should select any suitable date on the calendar and do it at that date every month. The person should be doing the breast examination without clothes in a standing and in the lying position. You should observe the breasts and see if there is anything visible in the shape or a lump or a color change in the skin or a texture of the skin as seen in the mirror. Then the position of the nipples, if there is any change, if there is any elevation or depression of one nipple. Subsequently, use the hands and compress the nipple gently and see if there is any discharge or any nodularity beneath the nipple. Then the finger should be used to check the armpit. The armpit contains the lymph nodes, which are involved to the maximum in any breast cancer. Then the fingers are used to examine all the zones of the breast. After this, the same examination should be repeated in the lying down position. By this, you become familiar with your own breast, the look and the feel. Now, what is X-ray mammography? As Dr. Praveen had pointed out, X-ray mammography and accompanying ultrasound are usually only things that are required for a breast screening. Further advances like tomography, MR breast, and others are done only if there is a particular need. So for screening, these two modalities are more than enough.
Please change the slides. I think slides.
Is the mammography machine visible? Oh.
No.
Okay, 1 second.
Okay.
Is it visible now?
Okay, continue.
So the X-ray mammography machine shows the paddle of compression and the table on which the breast is placed. Subsequently, we can see that 2 routine projections are taken in every case. In the picture are provided the up to down compression view of the breast and below that the side to side compression of the breast. Now, if you can appreciate, some part of the image is gray and some part of the image is more white. Now, what is the difference? When a patient or an individual woman has more of glandular tissue, then it is more white. So in this white area, if there is a lesion or a growth, then that will also appear white. So that is the difficulty which the routine mammogram can face when the patient has a lot of glandular tissue or a fully white breast. That is the scenario when the accompanying screening ultrasound is much useful to detect the lesion within the glandular tissue. In the area which is gray, that means there is more fat. In this area, a small lesion which appears as a white opacity or a white mark will be more clearly appreciable. That is why ultrasound plays a crucial role in being an accompaniment for screening mammography. Mammography screening guidelines in the average risk woman. As already pointed out by Roy sir and Dr. Praveen, in our scenario, we advise screening to start at least by the age of 40. Subsequently, the guidelines or the advice by the radiologist and the clinician will be followed by the patient to continue annual level of screening of mammography or to follow up for ultrasound and then screening by mammography at particular other intervals. Black, Hispanic, and Asian women have a peak incidence of breast cancer in their 40s and should begin screening at least by the age of 40. Global perspective. Now, what do you do if the patient has increased risk? In women with increased risk, as in a strong family history or ovarian cancers or known genetic mutations such as BRCA1 and BRCA2, or even in the cases of prior radiation therapy to the chest, including mediastinal tumors and lymphoma, they have increased risk. For such women, further screening should be advised. Earlier and more frequent screening should be advised for all women with increased risk. Usually, if a woman's first degree relative, such as a mother or a sister, has developed a cancer breast at the age of 40, we should start at least 10 years prior. MR mammogram helps avoid the cumulative radiation dose of repeated mammography in that individual. The healthcare provider can assess your individual risk and advise you on the frequency of screening required. The global perspective. As we all know, October, Breast Cancer Awareness Month, which is observed worldwide. Goals: awareness, early detection, research and fundraising towards breast cancer. Breast cancer is fast developing as the most common cancer in women worldwide. Early detection or earlier stage detection leads to higher survival. What are the challenges we face in this role? A painless lump is often ignored because it is painless, they think it is trouble-free. That is a myth. So despite literacy, especially in the population of Kerala, breast self-examination is not at all widely practiced. Limited knowledge of genetic and family risk should be ingrained in the public, and they should be educated on the increased risk and to attain and medical help and to go for routine screening earlier. Delayed reporting even of a self-detection of a mass. What happens is the patient often comes to us saying, this mass has been there for 5 to 6 months and now I have come. So it is that 5 to 6 months is lost in that person's life. What about the fear of cancer? Fear of cancer is universal. When it comes to you, you are worried. But our role is to educate the people and be more society friendly so that they are at ease to approach you. The targets of this program are to raise awareness of the painless lump. The painless lump is the most common symptom of breast cancer. Other symptoms include changes in skin, lump in the armpit, bloody discharge from the nipple, and change of the look and feel of the breast. Promote breast self-examination. A person who is well educated about the feel and the look of her own breast can detect any slight change very early. Then the person should feel free to approach the doctor. Screen high-risk groups with mammogram, especially those with family history or chest radiation. Access to health facilities should be utilized well. In Kerala, we have good health facilities and it is widely available in even the rural areas. That should be utilized so that we can increase the breast screening and reduce the deaths associated with breast cancer. We should publicize survival and hope stories. What are the myths and facts about breast screening? No lump means no cancer. This is what we hear day in and day out in our practice. The fact is, mammogram detects early cancers even with no mass. So, the patient and her relatives and the society at large should be educated saying that no lump does not mean no cancer. No family history means I am safe. Family history is definitely not a must. There are so many other factors. Nulliparity, chest radiation, and other factors. Mammograms are painful. What is the reason for this pain during mammogram? When the breasts are compressed, as shown in the mammography machine, the breast tissues are compressed for a reason. The glandular tissue, as I showed you previously, the white tissue should be compressed so they are widely separated, and any small opacity which is hidden among the glandular tissue should become more visible. In fact, there is only a mild discomfort during mammography. If the patient is well educated that the hormonal cycles are in play, which result in the tenderness of the breast tissues during compression, they will be more receptive due to the mild discomfort during the mammography. Danger of radiation. Now, if the society is more educated about dangers of radiation, they also fear mammography. In fact, the radiation dose of a mammogram is very slight. It is around 4 times a chest X-ray or 1/4 of a spine X-ray. So it is not to be feared. Breast cancer screening is only for old women. This is also a myth in society. It should start as early as 40. Concluding, our society should stand to gain from programs such as today's, which are held by the cooperation of IRIA, AMMA, and Swasthi Foundation. We should make it reach to the grassroots level, spread awareness about breast self-examination. Mammogram is quick and life-saving. This should be spread as far as possible. Early detection means saved life. In the era of such good cancer treatment, just early detection goes a long way to improve the survival. Talk to your doctor about assessing your risk factors and act on it. Start screening at 40 years. Thank you.
Thank you, Dr. Anusha Varghese, for that expert talk and dispelling many myths with a lot of clarity and expertise when it comes to cancer screening. Now, I'd like to ask 1 or 2 questions. Usually, these are the questions which we come across when we are conducting cancer detection camps. Usually, the public asks, are this screening tests safe? Or how accurate are the screening tests like mammogram? So these are the some of the common questions they ask.
Yes,
So you can
Dr.
answer
Devi.
that.
Yeah, screening tests, especially when they are used in conjunction, that is mammogram, screening mammogram and ultrasound of the breast, when they are used in conjunction, they go almost 100%. But very few cases you can have still need for clarity. That is when breast tomosynthesis and breast MRI play a great role. But for the vast population, X-ray mammogram and ultrasound of the breast go a long way. They should be popularized and utilized, especially in Kerala, where it is really widely available.
And what happens if a screening test shows something abnormal? Does that always mean cancer? So that is another question which usually comes from the public.
Yes. So according to the American Cancer Society, we have ACR-BRAD's guidelines, and they are graded from 1 to 5. So we have 1 is negative. So if breast MRI report, breast mammography report comes as BRADS 1, that is negative for any worrisome findings. If it is 2, it is for benign finding. That means such as a harmless cyst or a harmless small solid lesion like a fibroadenoma or a lipoma, and they can be left alone. If it is 3, it is a probability of a benign finding, but we may need a follow-up ultrasound at 6 months just to confirm. Further grades include 4 and 5. When it is 4, they are subsequently classified into A, B, and C. If it is B and C, which are more worrying, we need to have a histopathology report or a biopsy done to confirm if it is a problem lesion. When we put BRADS 5, it is almost confirmatory of malignancy or cancer, and it just needs to be confirmed like 95+% that it is going to be cancer. But 4B and 4C are the ones that need histopathology just so that we need to put it in a malignant category or in a benign category. So the percentage of positivity in 4A, B, and C vary widely, but 5 is definitely, almost definitely cancer. So just by doing a mammogram, many a patient can be totally pacified and can rest in peace knowing that they do not have a worrisome finding, definitely only a benign finding and such.
Thank you, Doctor, for the very detailed explanation. Now we have come to the end of the technical sessions. Dr. Roy, would you like to add something for concluding this technical section?
Okay, we had 2 very good presentations by Dr. Praveen Kesav, leading interventional radiologist, and eminent radiologist, Dr. Anusha Varghese. Again, making one point very clear that stage 1, it is asymptomatic most often. You will not have any lymph nodes, so you should not detect cancer at that stage. Our aim is to detect cancer at an early stage. Spread this message. Thank you, Dr. Anusha and Dr. Praveen Kesav once again. Thank you, the anchor. Thank you all.
Thank you. Thank you. We have come to the end of this webinar. ഇന്നത്തെ ഈ വെബിനാറിൽ പങ്കെടുത്ത എല്ലാവർക്കും നന്ദി അറിയിക്കുന്നു. പ്രത്യേകിച്ച് നമ്മുടെ ക്ഷണിക്കപ്പെട്ട അതിഥികളായി എത്തിയിട്ടുള്ള ബഹുമാനപ്പെട്ട ജില്ലാ കളക്ടർ ശ്രീമതി അനുകുമാരി IAS, ഇന്നത്തെ ഈ വെബിനാർ ഇവിടെ ഉദ്ഘാടനം ചെയ്ത ശ്രീ ഗോവിന്ദ് പത്മസൂര്യ, അതുപോലെ നമുക്ക് വളരെ വിലപ്പെട്ട അറിവുകൾ പകർന്നു നൽകിയ ഡോക്ടേഴ്സ്, എല്ലാവർക്കും എല്ലാ അസോസിയേഷൻസിന്റെ പേരിൽ നന്ദി പറയുകയാണ്. ഒരിക്കൽ കൂടി നന്ദി പറഞ്ഞുകൊണ്ട് നാളെ സെയിം ടൈം കാണാം. എല്ലാവർക്കും ശുഭരാത്രി നേരുന്നു. ഗുഡ് നൈറ്റ്. താങ്ക് യു വെരി മച്ച്.
Thank you.